All right. Good evening, friends. Welcome to yet another episode of webinar for the Gujarat WhatsApp group pediatricians. Dr. Ramesh Bajania is the main person who created these groups, and for last several decades now we are using it. In fact, I have lost the count how many webinars we have done so far. So every time I should tell, but today I'm not going to say. Because this is more than a year now since we started again with this monthly webinar, and we choose a topic, and we have some three eminent national international faculties. So we did one on the first seizure, unprovoked seizure and management, and then we ended with when will you label that as epilepsy. We will start from there, and now we will discuss the epilepsy. But as the time constraint, we will not be able to go into details of the syndromic epilepsy, because that itself is a topic by itself, like more than 20, 30 syndromes. So we will probably maybe touch upon, if the faculties highlight some few important syndromic epilepsy, but in general, our discussion will be only on epilepsy in general. So I will now request Dr. Bajania to introduce the faculty.
Good evening, all respected seniors and dear friends. Welcome yet to another yet again webinar from Gujarat Pediatrician WhatsApp group. And as we know, Dr. Nitin Bhai has been backbone of our academic activities. So at the onset, special thanks to him for being there in the group since beginning. As one can see, Nitin Bhai always goes for quality speakers. So there is, always one can expect unadulterated academics as usual. Now we have a very eminent pediatric neurologist whom hardly we need any introduction, but still, Dr. Rajesh Udani sir, as we know, is from Hinduja Hospital, and नाम ही काफी है. Second is Dr. Vinayan sir from Amrita Institute, Cochin. And third, Dr. Nitish Vora from RICN, our own from Ahmedabad. So at the end of a session, the viewers will definitely realize that how much pain and efforts Dr. Nitin Shah sir has put in to make it user-friendly, specifically for those who are into private practice, and still especially those who are in periphery. So not wasting much time between me and academics, straight away, let us go to the academics. Nitin bhai, yes, please.
Yeah, sure. So we all also welcome the guests which are present here. Dr. Jitu Gavane, my very good friend from Navi Mumbai. We have Dr. Ajay Kumar Gupta. We have Manish Mehta. We have Dr. Jalil, Dr. Darshan, and some Krunal, of course, my student and now a colleague from Vapi. So many people are there. Uh,
Yes,
uh,
Jitu Gawane sir,
yes, I
welcome.
said
Yeah,
first, yes.
yeah.
And
Sir.
for the viewers, this entire episode is being recorded and will be then archived on the Gujarat Pediatricians YouTube channel. And all the previous 11 episodes are there on the YouTube channel, including the last one, which was on the the first unprovoked seizure. So anyone who has missed or would miss this time can again actually at leisurely visit the site and view it. And for those who are present here and they want to do it again slowly, they can also do the same. We will very shortly share the link of this particular episode once it is uploaded on the Gujarat Pediatricians YouTube channel. So with that, we start with today's program, and I would first request Dr. Brajesh. I mean, we all say the epilepsy would mean maybe one unprovoked seizure with some red herring signs, or generally two unprovoked seizures, and then you will say epilepsy, and then we'll discuss as to what is the etiology, how do you go about, when to treat, when do you do EEG, when do you MRI, all that questions come. But first, we have to establish that it is a seizure and not a seizure mimic. So there can be a lot of seizure mimics which look like seizure and get completely confused, especially a young pediatrician who has just come in practice, haven't been exposed to a good pediatric neurology setup, and may think all those what do you call the seizure mimics as the convulsion and start treating. And many of them are actually put on anti-epileptic drugs. And when they don't respond is the time when they think that something is wrong. And then they refer to the neurologist, and then the neurologist will diagnose these are not actually seizures. So you can have all sorts of movement because of Basically, if you have migraine or a migraine-like disorder, including an abdominal migraine type, you have tics, you have shuddering attacks, you have night terrors, night walking, myoclonus at night, etc. So, Dr. Brajesh, can you throw some light and show some videos of your patients so that it becomes easy for a pediatrician to understand when do you call this as a mimic and not a seizure?
Yeah, I think so. What I'll do is see, you can't have videos for everything, but I'll show you a few case examples and you tell me when to stop because,
No,
I
sure.
have a 8, 9 slides.
So
I
you
don't
can
know.
start, you can share your.
Unfortunately.
So this is the only part where there'll be a PPT. Otherwise, we always do in a question answer. So once Dr. Brajesh Udani finishes showing 4 5 cases of mimics, then we'll go back to the question answer. Are you able to share your screen, sir?
Sorry, I've gone somewhere wrong.
Okay.
Am I again trying it? Oh shit. Oh God.
You are not
Uh
able to see the share button?
no, I went somewhere else. Sorry. Now I got it.
Okay. Yeah, we can see it. Can make a full screen,
Yeah.
Yeah,
So
perfect. We
basically,
can see it very clearly,
uh,
sir.
yeah, this is just a kind of few videos which are very simple. Most of you will be
See a little
easily
louder, please.
most of you will be able to easily identify these events, but I'll
Okay.
just. So this is a neonate, day 7 onset, multiple bilateral jerks. So I have to. This baby was started on phenobarbital.
Hmm.
So I've just gone to the different parts of the body which are
So they were
jerking.
like multifocal type of movements.
Yeah, yeah. I'm jumping a little ahead.
Okay. There's also scissoring.
No, this was just the baby was. So you got this multifocal, they are myoclonic clonic jerks,
Hmm.
means they are rhythmic. As you can see, it's bilateral and so on. So I'm
Hmm.
sure all of you know this.
Yeah.
So this is starts on days about a week and goes on for a few months and is benign neonatal sleep myoclonus. Main thing is happens only in sleep and remember the eyes are closed all throughout. So
Hmm.
it should be confused with seizures and you should not treat these.
Rajit bhai, we can't hear you well. You need to speak a little
I don't
louder.
know. Everybody can hear me. Only you can't hear me.
No, everyone, even Nitish said that he can't hear.
Uh you
Now
have.
better. Now better.
I better make it so close because there's no other way I can do it because I'm.
Yeah. This is perfect now.
Okay, so this is a
Yeah.
6 month old with periodic jerks,
Okay.
suspected infantile spasms. There he goes. One
Hmm.
jerk, second jerk,
But he's responsive all throughout.
third jerk. But in spasms, it's very difficult to know responsiveness because it's very
Hmm.
brief. So it's very
Okay.
brief. So essentially, it's just a bunch of jerks, and the baby otherwise is normal.
Hmm.
So I'm sure all of you know these are shuddering attacks or benign myoclonus of infancy. So these are basically seen in babies, usually, after a few months, 6 months, 8 months, and they are usually occur when they're excited, when they're happy, that kind of thing, and they disappear soon. And they're
Okay.
sort of stereotypic kind of behavior. And this is a kid who was having generalized tonic-clonic seizures. This is the first video. So this looks like a generalized tonic seizure. And there you see the other attack. This is a little dark.
Hmm.
And now you know exactly what this is. His lips become blue. He becomes, he's got his breath held in expiration,
Mm-hmm.
becomes stiff. He's actually having a hypoxic event, hypoxic seizure. And these are, as you must have all guessed by now, cyanotic breath holding spasms or cyanotic syncope. So this is one type of syncope which occurs in babies, and many
Mm-hmm.
of them will have syncope afterwards as they grow older also. So this is one of the kind of, and this is of course 3-year-old supposed to have an intermittent tonic seizure. So she would just before sleep she would cross her legs and go
Mm-hmm.
in stiff posture, and if it was disturbed she would start being upset. I'm sure all of you know this.
This is self-stimulation.
Yeah, self gratification. So
Okay.
it's a kind of infantile, pleasure-seeking thing. Happens mainly in girls and usually disappears by itself. This baby had a boy had a 6-year-old boy had an intermittent uprolling of the eyes. So I'm showing you according to age. So initially
Okay.
neonate, infant.
Sure.
So this is a boy.
कंट्रोल कर मत कर करने का नहीं
So I've asked him to stop doing it,
कुछ नहीं कर
and he's
नहीं
still,
मत कर करने का नहीं कितना देखने का
so he can control it, but it takes a lot of difficulty,
मत कर
and he can control it.
अच्छा अबे करने का तो कर
And now I'm allowing him to do it, and it comes up much more. So this is
These are ticks.
ocular tics. Yeah. This is a child who gets up in the night and has a thought to be complex partial or what is called focal unaware seizure. He's gone to pass urine in
Not
the
there, not there,
corner.
Babu, not there. Go to the bathroom. Yeah.
He appears anxious and crying, but he's following his mother's orders. He goes to the
Hmm.
bathroom, passes urine. We have tachycardia, sweating, all that kind of thing at this time. And this is, of course, night terrors. I'm sorry I
Mhm.
didn't. Now, 1 minute. This is a 14-year-old adolescent girl, recurrent loss of consciousness with generalized jerks preceded by dizziness. And she also has recurrent migraine headaches. And as you can see, the EEG was done, and she has these very prominent epileptogenic spikes, epileptic spikes from the central region in the sleep EEG. She was put on treatment, but if you look at it, the story was that she was upright. She would become, it always happened in the upright. She would become pale. She would feel some dizziness before, and it was obviously a syncopal episode. So we subjected to her a head up tilt test.
Mhm.
And as you can see, at 6 minutes, heart rate is 116, her BP is 100 systolic, and at 8 minutes when she's tilted up, suddenly drops to 53. The BP is not recorded, and she gets the same symptom. And as soon as you tilt her back to horizontal, she is fine. So this is a diagnosis of convulsive syncope. This was a very famous video. It's available on the net. These are young adolescent girls who are fasted. And when they are dropped like this is a syncopal episode, but he's having convulsions. Few jerks. So convulsive cardiogenic syncope, neurocardiogenic syncope occurs in 20% of patients. Very often
Mhm.
migraine and syncope can go hand in hand. EEG can be abnormal even in these conditions. The only point to remember, if these syncopal episodes are precipitated by exertion like climbing stairs and all that, please look for cardiac causes. And this is a 11-year-old boy with frequent daily episodes of staring, and then he has a head body drop, and epilepsy in the past was there. Now he's having some learning disabilities and cannot attend school because of this. And he was being put on treatment without any effect. Now, this is what we do, a tuning fork test. We suspected it to be a psychogenic non-epileptic seizure. And I've suggested to the boy that if I put a tuning fork on your head, it'll give you a buzzing sound and then you will probably have a seizure. Now, kids are very susceptible to this suggestion, and there he goes. So this can be used in the clinic itself to even convince the parents that these episodes are actually, and if you, that this is a psychogenic non-epileptic attacks, and if you see eyes are closed, he looks like he's, but if you do an EEG at this time, it will be normal in the awake state. So suggestion can help diagnosis and can occur in non-epileptics for secondary gain. So if you look at patients in the clinic, non-epileptic events, generally, we did a study in Hinduja, but 20% were actually non-epileptic. And the most common are all these, syncope, need, sleep myoclonus, breath holding, etc. So I've shown you a few videos to help you. Okay, that's it.
Yeah, great. You stop sharing and we can proceed. Yeah. So, Dr. Vinayan, you were not there last time, of course. So we discussed about the unprovoked seizure and how do you manage acutely going up to status. Now, when will you label a child that he's having epilepsy? Let's start from there and then we'll go to the different types of epilepsy.
Yeah, see, thank you for inviting me here. So the diagnosis of epilepsy, we can look at it in two ways. One is the conceptual way. So the conceptual way is something like you have the baby or the patient has got a tendency to have further and further seizures. So this is due to probably an acquired brain insult, or it can be due to a genetic problem, or it can be due to some other pathology. It can be due to a systemic problem. So any of the things can be due to produce this. So that means what we call conceptually is epilepsy is a enduring predisposition of the brain to have further and further seizures. So this is the conceptual kind of approach. But conceptual thing we cannot apply it into practice. So how can we practice this? So the practice is primarily is by if you have one seizure and then you have a gap and then you have another seizure without a clear provoking factor. See, that means the provoking factors is like an infection or any other things which can directly produce a damage to the brain. That is a provoked seizure. But this is an unprovoked seizure. But the unprovoking, there is some kind of a kind of gray zone there, because sleep deprivation can be a kind of provocation. You can have some people with a reflex seizures like a hot water epilepsy, photosensitivity. All those things can produce seizures. These things are also included in the epilepsy. So that means a seizure with the arbitrary cutoff is you have one seizure and a 24-hour interval, another unprovoked seizure. One unprovoked seizure, a 24-hour interval, another unprovoked seizure. But if you have multiple seizures in the 24 hours itself, it can be still due to a kind of an underlying cause. So that is if you have an underlying cause, it can have provoked seizures for 2-3 days together. So that we will not call it as an epilepsy per se at that point. So the thing is that 24-hour gap is primarily a kind of arbitrary thing. See, it's like so somebody, it is not based on any evidence, I'll say. So the other thing is, if you have a clear cause, something like that is the newer definition from the ILAE, which says that even if you have one seizure and then theoretically that means you have 24-hour apart two unprovoked seizure, means you have a 60 to 70% chance of having another seizure, a third seizure. So that is why we say that it is you have gone into the brain has gone into an epileptic mode. So if you can predict that after the first episode itself, you can still think of that this is an epileptic seizure. But that is a little difficult in practice. So the best way out is 2 seizures, 24-hour apart. So that means one seizure today, one seizure after 1 week, or one seizure after 1 month. Then it is definitely, most probably, the child has got epilepsy. But if you have that, it is a very frequent or a very interval is very short. then you are not very sure in the first episode, but in the second episode, third episode, it's okay. You have the diagnosis is there because it is the chances recurrence of seizures is there.
Correct.
So why we
So
want to, yeah.
yeah,
Sorry.
so basically what you're trying to say that first seizure you give the benefit of doubt of not treating because the second seizure may not happen in 30%. Whereas when you have two or more, then the chance of recurrence is more than 60-70%. Suppose the second seizure is after 2 years, then the third seizure after another 1 year. These are very so infrequent. Will you still treat them in between or leave the choice to the parents?
See, the diagnosis of epilepsy and the decision to treat are two different things.
Correct.
We can club it together because diagnosis of epilepsy is something like we make for multiple reasons. It is some epidemiological reasons are there. There are some research point of view we'll make. So the treatment decisions are depending on what depends on so many things. It depends on the child, the family, the physician.
Yes.
So whether they are what kind of seizure you are getting. Is it a GTCS? So is it a kind of a prolonged seizure or kind of a what we call an onset status? A child has got one seizure, a prolonged event, and then another seizure, another prolonged event, means it is. So the decision to treat is different. What the point here is, one seizure, the chance of recurrence is 50 to 60%. Second seizure comes, the risk is going up to 70 to 80%. So the third seizure, it is almost like more than 80%. So that means a second seizure onwards, traditionally, we'll start treatment. So that is the period we will say that it is the child is having epilepsy. But it depends on if you have a nocturnal seizure, it's a mild seizure. And then febrile seizure is an exception. See, we cannot.
We discussed that at length in the last episode. So
we have to exclude this. So this is unprovoked seizures. So the decision to treat depends on what kind of seizures you are getting, what is the effect on the child life, and it depends on how the medical treatment, the chance of risk to the patient. So if it is a mild myoclonic jerk, whether we want to treat, you don't have to treat. So it depends on so many other factors. So
I understand. We'll come to that a little later when we discuss the treatment part. So last question before Dr. Ramesh takes over. Dr. Nitish Bhai, what is the incidence of seizures in general and epilepsy in general in the pediatric population?
Sure, Nitin bhai. So seizure in general, which can cover anything, will be around 5 to 6 per 100. So it's huge, very huge number, 5 to 6%. But epilepsy, as we discussed, they are unprovoked seizures. And it's usually counted as a 2 to 3 per 1,000, so 0.2 to 0.3%. And of course, with the more preterm babies, injuries, all those things, the incidence is on rise. And also with more awareness, people are coming out and it's increasing.
Perfect. All right. Dr. Bramesh, take over.
Nitish bhai, please continue. Now, what is etiology of epilepsy?
Right. So etiology, as we are discussing, these are unprovoked seizures. So you can have different things like in India, what commonly we have is structural brain injury, like following hypoxic ischemic encephalopathy, NHBI, hypoglycemic brain injury, sepsis, all vascular events, stroke, all those things. So tumors. Other is structural, but genetic structure like tuberous sclerosis, focal cortical dysplasia. So your structural malformations are there. Then very common is genetic epilepsies, which are channelopathies because of sodium, potassium, calcium, different ions imbalance. Like Munna by MBBS, it says chemical ka locha hai brain mein. So that kind of thing. So, but that's a genuine. I mean, it's normal. I mean, it's normal language. So you have a neurotransmitter imbalance or excitatory inhibitory imbalance, and then you get huge discharges. So I think those things are common causes, and all these causes excessive electrical discharge, or synchronous discharge, and depends where those discharges are. You get different kind of seizures.
Perfect. So I as a sub question, I used to remember as a student that we used to say GIMS. So it's a genetic, infection, immune, and then M is metabolic, S is structural, and then if you know nothing, then you say unknown. So that's how we used to remember the etiologies of the epilepsy. So Dr. Rajesh, specifically, a lot of this one is given on imaging to hippocampal changes and some subtle neurodevelopmental changes as a cause of epilepsy. Just throw some light about a lot of new things are coming up in this type of epilepsies. Unmute, Rajesh, unmute.
So, about the first question about hippocampus and epilepsy, that's a much more common problem in adult life. It might present in childhood, but initially it's infrequent and all that. And this pathology is called hippocampal sclerosis. And it could be present from early life. It could be present after a long febrile status or a other big status. It can be secondary to status. So there are many reasons why you get hippocampal sclerosis. And
Isn't that also the most treatable cause by
yes,
surgery?
yes. Usually in adult life.
Adults, yes.
In children, hippocampal sclerosis which occurs may often be a result of a long
Of
seizure and which
correct,
may not be the actual cause, or it may be part of a double pathology.
correct.
Anyway, that's not important. Important is that this is the most important surgical thing, which surgical treatment in adult epilepsy,
Perfect.
because it's significant causes temporal lobe epilepsy. About the second question was,
Neurodevelopmental issues and epilepsy.
yeah, so I mean, in hippocampal sclerosis or a
No, in
general?
general, like as a cause of epilepsy. Again, because they
Uh,
are unable to surgery, that's why.
Well, you mean epilepsy causing neurodevelopmental deficits would be more
Either way, or
appropriate.
neurodevelopmental disorders like
Well, in the
this.
sense, so there are. It's not that the developmental deficits cause the epilepsy. You may be
Hmm,
born with a condition where you have
correct,
developmental effects as well as epilepsy coming together,
correct.
called developmental epileptic encephalopathies. It can also be that the epilepsy itself can cause because of frequent seizures, because of changes in the brain,
Okay,
because of hippocampal sclerosis, because of many reasons, because of the different drugs which you give, which may cause some mild cognitive changes, etc. You may develop subtle neurodevelopmental defects over time. And
okay,
if it is very severe, we call it epileptic encephalopathy.
okay. Ramesh bhai.
Hmm. Now, Vinyan sir, which are the types of epilepsies?
Okay, the epilepsies, multiple ways we can classify. See, usually we go by the seizure pattern. Okay, so the seizures and epilepsy we might have discussed in the initial phase. Seizures is a one-time event and epilepsy is the tendency. It's an underlying disease. So if we usually try to classify epilepsy based on the type of seizure, which is a general thing is focal epilepsy versus a generalized epilepsy. So focal epilepsy means it is not the common misconception is either it is the body part, whether it is one part of the body is involved, it is called a focal seizure, and then
Correct,
both sides are involved, it is a generalized seizure. It's not like that. It is
correct.
in the brain. It is in the brain. Even a focal area, if it is a very critical in the brain, it can have a bilateral occurrence.
Perfect.
So it is a focal seizure. So how can we know that? So it is not based on or not only on the clinical pattern. It depends on the EEG. It depends on the imaging. So many things. So simple thing is, if you have a consistently very consistent, constant networks are involved in one part of the brain, we tend to call it as a focal seizure. If you have bilaterally, both sides are involved in one go, like classical examples are absence epilepsy. The prototype generalized seizure is an absence.
Correct.
Okay. And then you can have generalized myoclonic seizures and generalized tonic-clonic seizures also.
Correct.
But
Correct.
most of the generalized tonic-clonic seizures are focal with secondary bilaterality, or which we now call it as a focal to bilateral tonic-clonic seizures. But for a general, when a practicing pediatrician, this doesn't make any sense, because bilateral means generalized also for outside. So the point here is, what we try to see in any patient with a seizure is whether there is a focus. So if there is a focus, then there is an approach is different. If it is not a focus, the approach is different. So
Correct.
by generalized epilepsy, the classical is generalized absence seizures. That is the prototypic epilepsy, and myoclonic seizures are also usually generalized. And sometimes the idiopathic generalized epilepsy, there will be a generalized tonic-clonic seizures which are occurring. Otherwise, most of the epilepsies are focal seizures due to what Nitish sir has already told, multiple structural damages, or it can be due to genetic causes. So the epilepsies can be the other classification, which is based on the etiology. which you would like to me to tell now, or it is?
No,
it's
so we
okay?
can
These are
discuss that later.
Yeah,
Can
yeah.
you throw
are-
some light on focal epilepsy with impairment of awareness and focal epilepsy without impair? What is, I mean, how does this differ? And
Yeah, so that is the other issue. So the point here is focal seizures with impairment of awareness, or now the newer classification is coming again. It is impairment of consciousness. So
correct.
that will be published in the next 1 or 2 months.
Mhm.
So that is good. That is nothing like, see, basically it is that if you have an impaired awareness, the chances, or impaired consciousness, the chances of injury is much higher.
Correct.
So that is why it is still getting this thing, because otherwise the impaired consciousness just determines that it can be in the temporal networks. If you have a impaired consciousness, means during a focal seizure, the issue is it can come from the temporal networks even with a very small area of involvement, or
Mhm.
it can occur when the seizure spreads to a larger parts of the brain, any part of the body, any part of the brain which is starting the origin is from any part of the brain. You can have a for impairment of consciousness. So impairment of consciousness, which we call, is just a kind of a descriptor which just say that for a clinical point of view, a patient who has got an impairment of consciousness has got a higher chance of accidents. So that is the most important thing. And the immediate differentiation for a practicing pediatrician is, for a child who is coming with an impairment of consciousness, the immediate DD is either you are dealing with an absent seizure or
Correct.
seizure with impaired awareness or impaired consciousness. So how
Perfect.
can you differentiate these two? With the absent seizures are usually multiple events, very short lasting events, and usually their children will come back to normalcy immediately after that. But if you have a focal seizure with impaired awareness, they will have sometimes an aura, and then they will show some automatisms, limb
Correct.
automatisms will be there. They can go into a generalized tonic-clonic seizure, and most of these focal seizures with impaired awareness or consciousness, they will they will end up with a postictal confusion, postictal headache, postictal lethargy, and then they might go into sleep also. So if
Fine.
you have these two, the main thing is absent seizures, our treatment approach is different. Focal seizures
Sure.
with impaired awareness, our approach is different.
We'll discuss that later. So last question about the epilepsy types, Dr. Rajesh. Throw some light on this epilepsy syndrome, which is coming in a big way. They are the ones where you need treatment straight away. Don't wait for second, third seizure and things like that. And your treatment
Right.
also differs on which syndrome you are tackling with.
Yeah, so basically, an epilepsy syndrome, just to a concept of epilepsy syndromes is that, of course, all of these disorders have epilepsy as one of but when you have a specific age of onset, you have a specific type of seizure, you have a specific background of abnormal CNS or normal CNS. If you have a response to treatment is very good or not so good, or if you have a self-limiting, in the sense it's the epilepsy itself goes away in a certain period of time, or it's something which is long lasting. All these things will decide. If these things come together, we can say that this particular patient has this syndrome. So what are these syndromes? Common ones one should know. Of course, one is infantile epileptic spasm syndrome. So this is happens in infants usually between 3 months to 1 year, and it usually disappears in 2 years, but
Correct.
sometimes persist. There has these periodic jerks which occur in the morning when they wake up from sleep. They may have, you know, they will have very often a developmental regression with that. And this is absolutely an emergency. You must identify them and not call them colic or any other cause. This is really something which is very important. Second thing, for example, in older babies or who are, say, in febrile seizures, the important syndrome is the Dravet syndrome, which
Correct.
is again the sort of emergency, in the sense if you diagnose it wrong, because it comes with febrile seizures or febrile status, very often one-sided, hemiclonic, and may alternate, etc. And it's very early onset, usually below 6 months, but sometimes as early as 3 months. So these kids have
Precipitated by
initial
vaccines?
precipitated by DPT, in the sense it's
Temperature.
not precipitated, it's just a trigger which
Trigger,
happens.
yes.
Many patients with DPT-induced encephalopathy actually have the
Mane.
SCN1A.
Canalopathy.
yeah, which is there, which is the basic of this Dravet syndrome. And if you don't treat it, you treat it with wrong drugs like carbamazepine or sodium channel blockers, etc., you will worsen the situation, and therefore you might really cause more status, more brain injury, etc.
Sure.
So that's the third syndrome you must know in older children, school age, they're usually normal kids with self-limiting epilepsies. This might come usually nocturnal seizures. Sometimes they can be aware, focal aware seizures. They get up with some twitching of the what is called a select
Correct.
epilepsy. And the other one is the cilias. And that is basically the old one was occipital epilepsy, which can come with
Correct.
status, and vomiting, and autonomic symptoms. So these are self-limiting. They may look dangerous initially, but they are very. So you know that these can be either not don't treat them at all because they're usually infrequent, or if you treat them for a short period of time. Uh, and the last thing is, say example, in the older patients, adolescents, after the age of 10, 11 years, if they develop generalized seizures, which could be tonic-clonic or absence or, myoclonic, then you are probably dealing with what, as Vinan said, IgE syndromes. And these,
Mhm.
unfortunately, they are treatable, fairly easy to control in many of them with the right drugs. Again, the wrong drug will make it worse.
Okay.
And but unfortunately, they tend to persist. So you might have a long, you might be able, might have not a, you may not have a outcome which is very short. It may be a long kind of process. It may go on for many years.
Fine. So Nitish bhai, we have had a very elaborate discussion by Dr. Vinay and Brajesh about the epilepsy. How do you classify? Is there a simple way a pediatrician can look at the epilepsy? I mean, this is looking into etiology, genetics, type, age of onset, so many things. Is there a simple way of classifying epilepsies for a
Uh,
pediatrician?
so I think we'll say a very important thing is the onset of seizure, what you saw or what the parents saw.
Mm-hmm.
So yes, focal, generalized, and sometimes it's unclassified
Mm-hmm.
or unknown because, like, say, a patient had a seizure in the sleep, and when parents saw it was something different. Because and this onset in the brain, so we know brain is made up of lots of networks or wires and neurons. So if it's happening in specific parts, the focal onset. If it's involving big networks, bilateral networks, it's a generalized. So simple, if we say focal onset seizures or generalized onset.
No.
Generalized, we know tonic, clonic, myoclonic, absence, all those things.
Yeah.
Focal, of course, we know, I mean, it's from a different areas, so it can be like of motor area, temporal, occipital, those kind of things. And of course, with or without awareness, means consciousness, preserved or
Correct.
not. So all these measures are helpful to first focal or generalized, or and also sometimes it's very easy to say if there is any aura. That usually goes with the focal.
Correct.
This helps with the treatment, further prognosis, workup, and also possibilities of uh, cure or surgery, etc. So if it's
Yeah.
just a focal, generalized onset or if possible, and a loss of consciousness not. Sometimes if they are not clear, best thing is to write down exactly how it started,
Mhm.
what happens one by one as a step, and how it ended. I think that also can, as a description or even a video, will help neurologists to make a proper diagnosis later on.
Sure. Ramesh bhai, take over.
Yeah. Now, Rajesh bhai, age of onset of different epilepsies so that we can expect.
Narrow down the differentials.
Okay. So generally, just to make it simple, very early onset epilepsies, I'm talking about the first few months of life, are usually the developmental epileptic encephalopathies or structural epilepsies caused by all sorts of perinatal issues, etc. Occasionally, they are self-limiting. They're not very commonly self-limiting, but they can be. The benign epilepsies of neonates, of infancy, etc. Then the middle infancy or after 3 months or so, you have the bad epilepsies like spasms and Dravet's, which you already
Correct.
mentioned here. Then and so in the second, third year, the good epilepsies, The bad epilepsies are Lennox-Gastaut syndrome, etc., which where you get drop attacks, absence seizures, multiple things. These are all the bad epilepsies. So earlier you are, the worse it is. As you
Okay.
go into school age and as you go into adolescence, the bad epilepsies sort of go down and the better epilepsies go up. So you have self-limiting epilepsies, you have idiopathic generalized epilepsies, etc. So as a general thing, the type of, but when you say uh, what are the childhood absence epilepsy also is something which comes in childhood, but also
Correct.
can come in juvenile age. But again, the thing is that usually these are easily treatable. If not, they may last for a long time, or they may go, most of them go away, but the older ones last for a long time. But otherwise, they're not difficult to treat. The early onset epilepsies, unfortunately, are the ones which cause problems.
Some examples of very early onset, like neonatal, and some like adolescent. Just give one or two examples.
Yeah. So, for example, very early onset epilepsies, you may have. Uh, uh, I'm avoiding structural epilepsies because that everybody is very familiar with. But for
Correct.
example, metabolic epilepsies, which come in the
Hmm.
newborn period, like
Correct. Correct.
pyridoxal phosphate, others, which must be picked up because they're easily treatable.
Correct.
Then you have the developmental epileptic encephalopathies, which are mostly genetic, and these unfortunately are not very
Treatable.
amenable, even
Hmm.
though they are specific. Some of them, for example, SCN2A, which might be in the first few months of life, might be very amenable to treatment with sodium channel blockers. So generally, we don't like to treat neonates with sodium channel blockers like oxcarbazepine or eptoin or phenytoin, etc. But these specifically will respond to those. So these
Okay.
kind of precision medicine has come up
And
in neonates.
adolescents onset, some specifics.
Adolescent onset like juvenile myoclonic
Hmm.
epilepsy, where you have a girl, very often a girl, but even a boy, get up in the morning and brushing their teeth, they drop things, both the arms go. They don't usually fall because it affects the upper limbs. And
Hmm.
this may be remaining like this, may also develop absences, which can be a separate epilepsy, juvenile absence epilepsy, where you have these periods of unresponsiveness, not as frequent as childhood, but they can be also very disturbing. And then you have the generalized tonic-clonic. So you may have all these three as separate and syndromes, or you may have all them together. So
Sure.
when you have all of them, so that's the way you diagnose. And
Sure.
basically, they don't respond well to sodium channel blockers at all. In fact, may worsen. So again, you may have to choose the right drug, like levetiracetam or lamotrigine, etc.
Sure.
Okay.
Now, Vinyan sir, amongst all this jargon, when you think of EEG, and in EEG, what do you see? Because many times what happens that even after first episode, some of the learned parents, they ask for MRI or CT scan along with EEG.
See, the main thing is epilepsy is a clinical diagnosis. So it is not based on any of the images or any of the EEG imaging or any of the investigations. Because clinically, when the patient gets 2 episodes of seizures, you can diagnose epilepsy. So EEG is not a must, imaging is not a must. But what we are trying to see in EEG is, or EEG or any other thing is, what is the pattern? So because the many of the say epilepsy syndromes are diagnosed based on the EEG. So if you get a focal spike, it might point towards an EEG, a focal epilepsy. If you get a generalized 3 Hz spike and waves, it may point towards absences. But the problem here is we are doing an interictal EEG. Interictal EEG means when the child is normal. Child is the gold standard to pick up epilepsy if you want an EEG is a video EEG where you have to capture the events and then compare with that EEG. Then that is the gold standard where you can characterize the actual event, which is whether it's a non-epileptic event or an epileptic event. If it is an epileptic event, what kind of seizure is it? Is it a focal seizure? Is it a generalized seizure? Is it a myoclonus? Is it a tonic seizure? So we will be able to identify it very clearly. But the problem with that is this is very easy if the seizure frequency is very high, like a spasm. where you have every other or 2-3 hours, if you get a seizure, it is better to do a video EEG because that is the best investigation to pick up the abnormality. But if you have one seizure and the other seizure comes after 2 months, 3 months, then you will not be able to do this. You have to rely on an EEG. So, but that EEG, you understand that EEG is not defining it is an epileptic seizure. Sometimes a clear epileptic seizure will have a normal EEG. Classical is the channelopathy, Dravet syndrome will not have interictal EEGs, mostly will be normal. And the other way around, you have a child with a 6 years, 7 years, many of those children will have nocturnal spikes, what we call the centrotemporal spikes and other types of spikes, which we call the self-limited spikes. They may come with some syncopal episodes, some other non-specific things, and then you do an interictal EEG and an EEG, you see some spikes, and then without taking proper history, you brand it as an epilepsy. That is also very bad. So the point here, which I would like to say, that EEG is not a kind of a panacea to diagnose epileptic seizures. EEG is useful in the right hands, where people have to properly interpret that EEG and take it in the right context. But much more important, I will say, is an imaging, because if you have a structural cause like a tumor which is developing, so and the seizure can be a first presentation of a structural lesion. And in that case, an imaging is much more important, especially if the patient has got some alteration of sensorium and the child is completely normal initially and then comes with a seizure with an altered sensorium. Even if the child has got 2-3 episodes in the 1 week prior, there is one more episode, or another 2 days later, there is one more episode. That is the situation. EEG, much more than in EEG, an MRI or an imaging and other investigation will be much more important than an EEG.
Sure. So that brings us to Nitish. Nitish, it's spoke of MRI. So which MRI, when, and what is epilepsy protocol? We discussed in the last episode too, but
Yes,
maybe the crowd is different. So again, if you can just quickly recapitulate.
sure. So neurologic of choice is MRI, and MRI, if it's a routine, at least it should be good quality, good standard, 1.5 Tesla. Ideal will be more high resolution, like 3 Tesla. So our purpose is to get any focal onset, focal lesion, surgical amenable lesions, that's 3 Tesla. Which children to get the MRI? I think Ailey and other people have given good criteria. If your seizure onset is before, or epilepsy onset is before 2 years of age, because neonatal onset or infantile onset, get focal seizures, bad brain, other things. So less than 2 years of age. Other is either from the history, examination, semiology, or EEG, you feel this is a focal epilepsy. If child has any regression of milestones, or focal deficits, all those things, or if suddenly its child had, you think it's a state for epilepsy, but now child is refractory to medication or seizure types are changing. So things not fitting in a standard box, you do want to do the MRI. So MRI mainly to look for the lesion and what else is happening with the brain to find
So
the
MRI with the first episode of an unprovoked seizure, or only when you are deciding treatment with the second seizure?
No, so I think it depends. So if it's generalized epilepsy, even we don't do any MRI. So like say general juvenile myoclonic epilepsy, you don't need any MRI. But even like say if child is less than 2 years, or even a single focal seizure, or child has abnormal neurology, development abnormal, focal deficits,
Okay,
because even say Northern India, NCC, neurocystic sarcosis, or
sure.
even hypoplastic brain injury, you will have even first seizure, you will get the brain picture abnormal.
Correct.
Now, your other question was, what is epilepsy protocol? So
Yes,
routine MRI, what we are getting is 1.5 Tesla, which is standard to get basic brain structure. But when you're looking for finer details, you want to do 3
correct.
Tesla. And epilepsy protocol, it takes more
Cuts.
finer cuts. And
Yes,
usually it's by default, it's a temporal lobe. So unless you specify to the radiologist, like I'm looking for right frontal or left occipital, they will do that area more refinedly so you
correct,
can find the structure cause.
correct. Okay, so that brings us now to the treatment part. And Dr. Brajesh, what are the common AEDs that we use? And there are several which have come up now. So,
Uh, it should be, I think what one should realize is that though there are many agents which are used, the agents which are still stood the test of time are basically, for example, valproate, sodium channel blockers like oxcarbazepine. Carbamazepine has become a little bit out of fashion, but
Paxa.
it's still a great drug because you have to now do for medical legal
Really?
purposes, I mean, HLA test to make sure you're not prone to a Steven Johnson syndrome. Then you have the newer drugs, which has now become primary, is levetiracetam, which
Hmm.
is a very common drug, in fact, the most common. So there are two basic groups of drugs, the broad
Hmm.
spectrum drugs and the narrow spectrum drugs. The narrow spectrum drugs examples are sodium channel blockers like oxcarbazepine, phenytoin, which basically work mainly in focal seizures, and the broad spectrum work in both. So, for
Hmm.
example, valproate, for example, levetiracetam, for example, clobazam, etc. But generally, we tend to use the old horses for valproate, oxcarbazepine, levetiracetam as first line treatments. At least that's what I do. And the other drugs which are more expensive and newer in the market should be only used at a time when, if, for example, is not coming under control or something of
Hmm.
that sort.
So they're like add-on drugs.
Well, yes, with the second line or when you have a problem in controlling. So the
Hmm.
first add-on, second add-on, these are all basically every new drug has its own. So has its own advantages and disadvantages, which we can discuss with each drug. But basically, first line when a patient comes to you, this is what you should use. One caveat: if you have an older patient, and especially a girl who's in the adolescence, avoid using valproate because of its significant issues with metabolic syndrome and PCOS and all that. So basically, that is the one we avoid it. In very
Oh,
young infants, also, for example, newborns in the early parts, you may try and avoid valproate because but that is not, hard and fast.
sure. So some practical question to first Dr. Nitish and then to Dr. Vinayan. Do you increase the dose with the weight increase? Like how frequently? Like suppose someone is 12 kilo, you started in a dose. Now he's become 15, he's well controlled. Do you increase or you just wait?
No, so if seizure well controlled, I will not increase the medication.
Suppose he
Uh,
becomes 5 kilo more, 6 kilos more, like
yes,
a rapid growth during adolescence.
that's
Then
it. So no, in that case, I think you still keep the minimum which is helpful. So minimal which is helpful. So seizure freedom and no side effects. That's the best way of tolerate means you're balancing out. So
okay,
yes, if rapidly growing weight, yes, we'll try to keep the say around sodium valproate 20 25 mg per kg per day. You don't want to get dropped to 10 mg per kg per day, which is a huge weight gain. So younger infants and children, yes, you may to push with the weight.
Mhm.
You do regular follow-up, but teenagers once they are stable weight,
Okay.
2 kgs, it doesn't matter much.
Dr. Vinayan, your choice is normal drug or a sustained release preparation?
See, there is no specific advantage actually theoretically. If you look at the sustained release versus normal, it depends on what are you treating. Because
Mhm.
if you are treating a high frequency epilepsy and you have a higher chance of seizure,
Correct.
then you have to adjust it accordingly. So it is depends on, see, if you are treating nocturnal seizures alone, you can have only nighttime drugs. Okay. So it depends on what you are treating. So basically the thing is there is no hard and fast rules we can say because the companies are pushing for sustained release. But
Mhm.
there is no, if you take, for example, valproate sustained release and the valproate single dose, sorry, the regular drug doesn't have much difference because the efficacy is not only dependent on the levels. See, that is why we are stopped doing the drug levels nowadays, unless you are looking for toxicity. The
Okay.
toxicity is a different thing. So toxicity, we do the drug levels, but otherwise, what we are looking at is the efficacy part of it is purely clinical. So if
Okay.
you have a higher frequency seizure, and you know that there will be a higher frequency, you can actually increase the dosage and adjust the dosage accordingly with a sustained release or a regular drug. But basically, sustained release doesn't give you that kind of an advantage. Only thing is, again, if you have a peak dose side effect, like carbamazepine can have a peak dose side effect. So in that case, a controlled release will help. And
Okay.
then the other drug which comes with that is that levetiracetam has got a sustained release nowadays. And then the other carbamazepine, valproate has got a valproate. Again, I'll tell you that it is more of a pharmacodynamic effect, even with a very low dose. If it is an IgE, even with a very low dose and a very high dose, there is not much difference actually. If it is going to work, it works at a very low dosage. So
Sure.
it depends on so many factors. So I
Sure.
prefer to give a plain drug, but I use a chrono drug also, depending on what is the current what the patient profile is. So
Sure.
then the other thing is the basic thing which I would like to tell once more is you have to look at the what you call the half-life. So
Sure. Sure.
for some people, I have seen that for Eptoin, only one dose. It is theoretically possible to give one dose, but if they miss a dosage, then there will be a 48-hour gap. Then phenytoin is not a very good drug to give once daily dosage.
Sure.
But compared to that, phenobarbital, you can give a once daily dosage, because even if you miss a dosage, the drug level will stay for 3 to 4 days or more than that. So you can actually give once daily dosage. So, and perampanel is a once daily dosage. So it depends on the type of drug and the type of disease where
Sure.
we want to share between these two. Okay.
Sure. Dr. Brajesh, your talk on this chrono versus non-chrono, and valproate versus divalproate and things like that. I mean, there are drugs with similar name, but
Theoretically, valproate and divalproate should not make any difference because
but
there is
practically,
false. But practically, in my experience, I have found that the divalproate works a little longer, and you get better effect with divalproate. And maybe it is
so someone having frequent seizures in a day, there'll be better control with divalproate, is what you're trying to say?
no, not question of frequent or whatever. Efficacy wise means it controls the seizures. So we basically had some experience, which is personal experiences, like really not really objectively proven, but basically it's when you switch over sometimes from sodium valproate to divalproate sodium, I found this to be more effective in the sense you sometimes control the seizures you're not controlled initially. However, this is I would like to know what Vinay and Nitish think about this.
Yeah,
About
Vinay, one line, valproate
Yeah,
versus
sir.
divalproate.
No, sir. Basically, I will again say that it depends on the patient profile. And see, 3 things we can avoid. See, basically, a TID dosage in a school-going child, it's a very, very difficult, because we will try to give a BD dosage. OD dosage of divalproate, some people give, but I am not a very fan of that, because again, I prefer BD dosages of anti-epileptic drug, basically because of this risk. Because if
Sure.
you miss a dose, what will be a chance of going down the therapeutic range? So the
Correct.
chances are very, very high in valproate, very, very high in carbamazepine. So in such a case, it is better. Even in Neptoin, the chances are little low, but still there is a higher chance. So in those cases, even if they say that XR can go for 24 to 48 hours and all the companies prefer or companies push for that, I prefer to give a BD dosage unless there is a clear evidence to say that 72 hours this drug will last, because perampanel is a drug which will last like that. So you can give safely OD dosage. And the problem with the perampanel BD dosage is if you give it in the morning, the child may not tolerate it because of the significant sedation and significant neurological issues. So only bedtime dosage is possible. So
Sure.
it depends on, I'll say that in general, there is no difference between all these things. And BD dosage is a better dosage because there is a chance when you give a drug for 2-3 years together, there is a real chance of missing dosages. We can't blame the families or children that they missed one dosage, or they missed one, or they have a 2-hour gap, 3-hour gap after a dosage. So we have to expect that. In such a
Sure.
case, it is better to give a BD dosage. That is
Sure.
my take on that.
Sure.
So
Nitish,
to add to that, yes.
Yes, before that, just practical. Child says, I missed my morning dose, and he realizes in the afternoon. What does he do?
First and foremost, say give immediately when you remember.
Okay.
Ideally,
And then what happens to the next dose? At the correct time or the
so yes, I will delay for few hours,
okay.
and few hours will be 2 3 hours, but at least 10 hours difference between twice a dosing. Ideally 12 hours. Where you have nocturnal seizures, like what Dr. Tibinian is saying. So if you have Rolandic epilepsy or frequent nights seizure, I think those medications, even if you just see chrono or divalproate something the night, it helps. So even a single dosing in the night, those kind of seizures, it's helpful.
Okay.
And I'm sure migraine people, I think divalproate does help with a single dosing as well. But frequent seizures, I think twice a dose is very essential. So twice a dose is important.
So one important question, adolescent girls, some of them may become pregnant without knowing teratogenicity of the drug. So which are the ones you completely avoid in such situation?
So ideally, as Dr. Dani Sarsa said, teenager girls, sodium valproate, we are trying to avoid any way possible. And of course, phenytoin, carbamazepines are the bad things, and usually you are not using them. Most of people are not using it. So, terrorism bad with sodium valproate, yes. Oxorubicin also is very notorious about terrogenicity. I think
So let's say other way, safe drugs in adolescents.
sorry, same drugs in
Safe.
safe. Okay, levetiracetam is one of the relatively safe drug.
Okay.
So it's not 100%, but the one of the best medication efficacy is levetiracetam. And breakthrough seizure or something is you can add clobazam. Brivaracetam and levetiracetam as such, they are same in a way, but still brivaracetam data is not fully out for years and years or decades. So still in practice, levetiracetam is better than brivaracetam from teratogenicity point of view.
Okay. Ramesh bhai, take over.
Now, how do you monitor for response and compliance, Rajesh bhai?
Well, the best way to monitor for response is to actually have a seizure diary, which is almost unknown in the world of pediatrics in India. So it's not a all or none response. If you have a significant response in the sense, you know, your seizures from say once a month go to once in 3 months, it's a good response. It's not like so. Basically, a diary will tell you very clearly whether a drug is effective or not effective, and this is especially true for patients who have frequent seizures, because you may have say 10 seizures a week, and say after a month they come to you and say, well, now he's getting a seizure still going on. When you actually count them, they are, 3 seizures a week. So it's definitely worked. So you know that the drug you've used has helped. So you may want to push it up. On the other hand, if you have a drug which has not worked, there's no point continuing it, and you want to take it off. So clinical response is not just from the parents' memory or the impression. Of course, if the seizures completely go away, everybody is happy. But that is not always happens. And that's why you must be important. You must have a way to monitor efficacy.
And for the
Second thing is,
compliance.
1 minute, you also monitor for adverse effects.
Okay.
And sometimes the adverse effects are little subtle. They may not be obvious to the parents. So as a pediatrician, for example, if you are giving somebody valproate, or if you're giving any drug, many drugs, for example, and you're finding that the patient is putting on weight, he may not notice it and they may not really bring it to your notice. But if you check weight every time and you keep charting it, you realize he's jumping percentiles. And once, as you all know, weight put on may be difficult to get off. So adverse effects so you must know the common adverse effects of the common drugs. It is the drugs you use. You must know the effects. For example, levetiracetam, you would not use in developmentally disabled or autistic children because you know that the adverse effect will be on behavior. So you try and avoid them. So there are adverse effects. Before you start, you must try to minimize. And if it happens, then at least you look out for them. And the third is about what is the third thing?
Compliance.
Compliance. Now, this is obviously important only if the fits are not coming under control, seizures are not coming under control. And in my experience in pediatrics, compliance is usually pretty good, especially in younger kids. As you grow older and you're taking your own drug, that time compliance becomes a bit poor,
Correct.
and your drug levels might help in that situation to know whether he's taking the medication at all.
Correct.
Now, Vinyan sir, about monitoring drug level, how frequently, when do you do, and what sample?
So this drug level monitoring is a little complex thing because none of the newer drugs none of them need a drug monitoring. So the only drug monitoring is basically needed for in a routine practice, I am telling. For older drugs like phenobarbital, phenytoin, carbamazepine, valproate, these are the classical drugs. But the problem with this is now we know that if you go the standard, what we call the escalation therapy, where we go with Dr. Nitish was telling that, see, we go for the lowest possible dosage. And the lowest possible dosage, and our outcome is not on the drug level. We are looking at the clinical response. If the seizure response occurs, even with a lower dose, because it is not standardized, many people will behave differently. So even with a lower dosage, if it's at the therapeutically lower levels, some people will have a kind of very dramatic response. So you don't have to push it up to the therapeutic range in that situation. So the point here is, but at the same time, therapeutic drug level monitoring are needed when you are having a kind of a suspicion that they are not taking it and they are telling that they are taking it, and the
Correct.
child is getting seizures. So there is a conflict. So you can do a drug.
You already said for toxicity also you will do. I think we have lost him. His connection is gone.
Nitish
So
bhai,
till the time he comes back,
Nitish bhai,
Dr.
you may take
Brajesh,
over.
is it fair to say that you will do it in a patient who doesn't respond on the standard dose? You want to know the compliance and whether is the therapeutic levels achieved. Number two, if in a patient who is not responding, of course you will want to do drug level frequently, and if there is a toxicity, then surely you will want to do. You will do the trough level.
Well, well, the first question was about uh, what
When
was
do
the
you do
first
your
question?
first level?
Last level it was.
Do you do it routinely, or you do it only when there is
No, I never do it routinely.
correct?
And if you do it routinely, it should be only for phenytoin, because
Correct.
phenytoin is a very narrow therapeutic range, and you may go into toxicity, or you may go into lower levels without really having any reason for it. And that's
Correct.
why if you're using phenytoin, that's why most of us have stopped using phenytoin except in the acute situation.
Correct.
The second thing is, if you're having older drugs, like Vinyan said, and you're not getting control, you might
Control.
use
Okay.
diazepam. In the newer drugs, most of the times you don't need a level. However,
Correct.
there are two exceptions, especially if the patient is not coming under control. And one is, of course, oxcarbazepine, and the other one is lamotrigine.
Hmm.
So these two drugs have sort of some connection to the level, though it's not very one-on-one. Like the older drugs are very, phenobarb and carbamazepine is on a very is very obvious when you see a low level, that is the reason. But over here, it may be other reasons as well. Levetiracetam, the newer drugs, all clobazam, brivaracetam, perampanel, topiramate, all these things, you don't need levels.
Perfect.
They
Yeah,
don't
that
have
is
any.
thing. I'll add that because these drugs are definitely actually the designed not to have drug levels because
Mhm.
there is no pharmacokinetic interaction. The protein binding is very low because these are
Mhm.
the things which affects the drug levels. Because if you take this, the drug levels are needed when you have a say constant dose you are taking. Even then, you have other factors getting into that and then fluctuate the drug levels. That is the situation. We need a drug level actually. But in the
Sure.
newer drugs, you don't need that because the pharmacokinetically, they don't have that kind of an interaction with the other drugs. They don't have other interaction with the foodstuffs. They don't have that kind of protein binding. Then overall, whatever you are taking, it will be there in the system and that will be binding to the receptor. So if you have that kind of system, very rarely you need. And except Sir was telling, and the other thing is not the pediatric. The other one is when you have a pregnancy, you can have a sudden increase in the the volume of blood, then you can get suddenly
Sure.
there can be drops, but that is not a pediatric
Yeah,
issue.
we won't discuss that because that's pure.
Yeah.
So Nitish,
And
yes, Rajesh, yeah, go ahead.
you said about trough and peak. Now,
Yes,
usually after a steady state is reached, usually, if you're toxic, it doesn't matter when you do it. Though, of course, if you do peak levels, you'll probably get a higher peak level.
correct.
In efficacy, yes, trough level will be the
Rough
better.
levels. All right. So, general principle, Dr. Nitish, when you have a patient who is not responding to one drug you have started, you increase the dose, maybe you check the levels, they are in levels. Now you know he's not responding to that drug that well. So, when you add a drug, you add a drug or you substitute a drug.
Sure. So I think it's very important few points to clarify at that stage. These are anti-seizure medications. These are not anti-epileptic drugs.
Correct.
So they just control the seizures.
Correct.
At any stage, if you're not getting seizure control, again, you check compliance and you go back to basics. Am I right with my diagnosis? Again,
Mhm.
go to the history. What are seizure types? Are these epileptic? What is syndrome type? Am I missing anything? And then choose the right drug
Correct.
for that seizure syndrome.
So
And
all that is
patients,
done and is not
that's right.
responding.
So and then also have a chat with the family what their expectations are, and everything is smooth. Then and if it's a bad epilepsy, in that case I will do add on.
Mhm.
And if there are issues with the drug suitability,
Mhm.
I replace with something else. So
Correct.
ideally, I would like to continue with the monotherapy if possible.
Mhm.
And that's a drug is not effective. That means you have given the right drug, right dose, right duration. So at least 3 months trial and patient's compliance is good. Everything is right. And still it's not working. You would like to replace with something. That's
Correct.
replacement. But if it's a bad epilepsy or seizures are not getting controlled, you want to do add-on. So
Correct.
replacement, usually what you do, you keep one these dose on the possible highest possible dose without
Mhm.
side effect, and still not working, you add another drug. And once the second drug is on the nearly good level, then you gradually drop off the first dose,
Okay. So
first
you
level.
overlap.
Yes, I definitely overlap.
Okay.
And if it's add-on, of course, you starts low and go slow. There
Sure.
is another good medication is clobazam. So for tie or those period where you have more chances of
Ah,
rebounding, you can use
okay.
clobazam for short period.
Correct.
Of course, side effects. So either you would add on or replace.
So, Dr. Rajesh, you have, I mean, I see many of your patients at Hinduja, they are on multiple ADs, 3 drugs, 4 drugs, 5 drugs. So then when you give them, do you, I mean, how do you schedule them? Are they at random or they are one after another or?
Yeah, let me clarify that the ones on 3, 4 drugs are
They're
drug
required.
registered. It's not my usual practice to give 3, 4 drugs. Anyway, the point is I prefer to give all the drugs at one time.
Okay.
It should not be given. I mean, you may give it over 3, 4 minutes or 5 minutes, but to
Yes,
give it
yes,
1 hour
yes.
later and 2 hours, it doesn't make sense because these drugs, unless there's a absorption problem, which usually there is not. So if you
Correct.
give 2 drugs together, and there's a kind of there's a absorption issue, then of course you may not. But as far as anti-seizure drugs are concerned, that is not usually a problem. So you give it
Perfect.
together.
Okay.
And second thing is you never wake up a child to
Oh,
give a because
okay.
I've got many cases of parents saying उसको
They
6
don't
बजे
put an
रात
alarm.
को हाँ तो 6 बजे उसको उठा के दे देते हैं in their sleep
Ah,
also. So
correct,
that
correct,
must be after. So you just basically do it dinner and breakfast and dinner or something of that
correct.
sort.
So we have half
And
an
you
hour
don't
more
have
and
to,
we have,
many things you do not need to have it with food. Many of these
okay.
things can be given on empty stomach as well.
Fine. We have half an hour more and a lot of questions still. Maybe we can take in a rapid fire format. Dr. Ramesh, please take over.
Yeah. Now, common side effects, Rajesh bhai, and how do
Let's
you
say
manage?
one by one. Let's say Valproate,
Yeah.
2 common side effects.
So 2 common side effects. One is weight gain, and second is loss of
Tablets.
hair and hair
Liver
loss.
toxicity.
Rare, very rare.
Okay. And thrombocytopenia.
High dose, yes. High
Yes.
dose,
Okay.
yes. Normal
Okay.
dose is very unusual.
Okay. Dr. Nitish, carbamazepine or oxcarbazepine.
So
Soft
first and foremost, rash, allergic rash,
rash.
and
Okay.
enzymes inducers and drug interactions.
Cytopenias.
Yes, and also hypothyroidism on the higher
Okay.
doses.
So we see sometime pure red cell plays a like picture in a patient who is on carbamazepine, and you withdraw the drug and it starts
Absolutely correct.
becoming better. All right. Third, okay, Dr. Vinan, topiramate.
See, topiramate is usually weight loss is the main complaint when you have
It's a
that.
good thing for some people.
Yeah, so it depends on the group we are using it,
All
and
right.
then you can have renal stones.
Renal
So
stones.
that is one which you have to take with a lot of the good volume of water.
Okay, Rajesh Vigabattin.
Vigabatrin essentially short-term use is not very high risk of side effects in children, but visual side effects are, of course, one thing. Obesity is other thing, and third is sometimes they, especially infants, when you use it for infantile spasm, they can get changes in the brain, which are usually transient and not really a problem, and sometimes can be symptomatic.
Okay. Do you all give routine vitamin D and calcium because some of these drugs can also have effect on the metabolism?
Yeah, I
That's
Dr.
always.
true.
Nitish?
Yes, and I think we definitely give routinely. And
Mhm.
my practice is I usually look at the birth a month. So whenever
Mhm.
they're coming near to birth month, I give vitamin D, 60,000 every week for 8 weeks or so. So they do get vitamin D every year.
And after that, you continue every month. Age appropriate dose.
Yes.
Correct. Dr. Vinan, potentially lethal side effect, which can lead to medical legal issues, like Dr. Resh mentioned. There was a case against a neurologist for not doing the HLA typing before using the drug. I mean, do you do it like what are the tests that you will do before starting most of the AEDs?
See, that is so if things go wrong, people can complain at any time because we can't do everything under the sun
Correct.
when you do start prescribing. So basically, if you have some drugs where there is a very high chance of side effects, see, so something like valproate, I'll do a hepatic function and a
LFT. Okay.
LFT
Yes.
and counts before starting that.
Correct.
So that is, and then if you have cannabidiol, if I am starting again, I'll do that kind of hepatic testing. And then
Correct.
if it is a topiramate, I do go for ammonia and renal
Mhm.
function testing.
Perfect.
So some drugs we will do that.
What
But
about
carbamazepine,
pyruvate, lactate?
what is that?
Pyruvate, lactate, one of the ABG before
Yeah, so
starting.
you can do that. Theoretically, valproate is a mitochondrial toxin. So you can get thyroid function test also a baseline thyroid function abnormal
Correct.
is also a better thing before starting.
What about HLA typing before
HLA
carbamazepine?
typing is a kind of really a questionable thing because
No, so
the
is it the
point is,
standard of care now after that
yeah,
medical case?
I know that. But the problem here is the better thing will be you see will be especially the South Indians. You have a
Uh-huh.
higher chance of HLA,
Oh,
this HLA abnormality, which has been described.
B1502.
Yeah,
Okay.
that has been described from the Chennai, and multiple studies have shown that. So
Because the
we
case
have a
happened there
higher.
somewhere down south
Yeah, so
itself.
then it is better not to do. See, what I am doing nowadays is the
Not to
prescription
use.
of, yeah, that is it. See, better why? See, we have, see, even if you start, unless you have a real indication to
Okay.
continue that, so you have other drugs. So it
Okay.
is better to start that rather than exposing the child to a
Perfect.
unknown thing, because this is not drug dose dependent side effect. This is an
Correct. It's a
idiosyncratic
idiosyncratic
side
side
effect.
effect.
It's an
Absolutely.
idiosyncratic side effect. It can happen
Right.
at any time. It may not come in the initial phase. It can come
Okay.
later also. So it is always you are on it's a risk. So it is better, you see, in our practice that definitely the carbamazepine dosage has come down, like sir has already
Correct.
told that.
Correct. Nitish, on follow-up, do you do testing like CBC once in 3 months or LFT or you
Uh,
do it only when there is some problem like side effects?
no, usually when there is side effect only, otherwise not routinely every 3 months is 6 monthly.
Rajesh, you do CBC
Especially,
routinely?
but someone who is getting, so I think thyroid function test is something
Thyroid
with
function.
sodium
Okay.
valproate and oxalizin. If you're seeing child is getting dull or weight gain, all those things. So for
Okay.
sure. And of course, sodium valproate, you have a petechial rash, or if you see on examination,
Mhm.
ecchymosis, something like that, then
All
of
right.
course counts. And if child is drowsy, sleepy, vomiting, all those things, you'll check the LFTs, ammonia lactate, but not routine kind of every 3 months, 6 months. No.
Sure. The next section we are going to discuss very briefly choice of AEDs in a particular type of epilepsy, because it's sky's the limit to discuss the drugs, how to use, when to use, etc.
So
But
one thing before we move
the
on,
last question,
Nitin bhai,
that
it's
which are the drugs, Dr. Brajesh, we need to gradually increase, or all drugs you gradually increase, especially some which like levetiracetam or topiramate or
Well, generally, all the it's a good principle. We always start low and go slow.
okay.
But there are certain drugs which can be rapidly increased. For example,
Mm-hmm.
oxcarbazepine can be rapidly increased, though carbamazepine can't.
Mm-hmm.
Valproate can be started at a reasonably good dose, but for lamotrigine you can't.
Okay.
Topiramate you can't start at a high dose at all. You have to go very,
Correct.
very slow. But
Correct.
for example, even clobazam also you would probably start low and go slow. But generally, the principle would be to
Mm-hmm.
start slow, go slow.
Correct. And which
So
are the drugs which can lead to Steven
levetiracetam
Johnson?
also, levetiracetam also you don't have to start full dose, but 20 milligram per
Yes.
kilo starting is no problem at all.
And every 2 weeks you increase.
Yeah.
No, no
Okay, which are
standard.
the drugs?
I think it is
There's no
better not to
standard
give
as
a
such.
standard because it depends on the seizure frequency.
Perfect.
So
No,
what
absolutely.
you are treating, say, and then the drug which you are, sir has already told that some
Okay,
drugs
the
and
drug that you look for Steven Johnson and inform the people. I know a case against a pediatric neurologist that I was not informed that this can happen.
So lamotrigine is the one which is one of the
Mm-hmm.
higher.
What
That
about
is
carbamazepine?
carbamazepine is next on the list actually, but
All right.
lamotrigine, no, I mean, it's not very sure. There are some HLA studies which have been done in Delhi which have shown some sort of correlation with it, but it's not standard of care to check for any HLA thing for lamotrigine. But
And
definitely lamotrigine is number one, and therefore you have
correct,
to go very slow, especially if it's given with valproate. So you'll be
correct.
very, very slow with that. And
And
carbamazepine is number two. And
once
there's
you have
zonazepam.
once you have
Zonazepam
rash
also
with carbamazepine, can you use phenytoin or phenobarb, or they are the same group of drugs?
no, you
you
should
should
not.
not.
You should
You should
not.
not.
Yes. So I think these are important questions for pediatric, but they are still using those drugs, and they should know that once you have a problem with one drug, they are all this like the
So the drugs which can be used is levetiracetam and to some
yes,
extent clobazam.
perfect.
So other drugs, so the other drugs are little difficult because lamotrigine, phenobarbital, phenytoin, valproate, everything. Once you have, this is a class effect. So if
Class effect.
it's a
Perfect.
class effect. So if you have a skin rash, especially a mucosal rash, then you have to be careful with most of these drugs except a few.
Perfect. Now, Dr. Ramesh, you take just rapid fire choice in different types of epilepsies. We don't
Yes.
discuss in great detail, but just simple drugs.
Well, before sir starts, I think levetiracetam we have not discussed side effect. Usually everyone takes it's a very safe, very good. I
Mm-hmm.
agree with that, but it's a huge side effects on the behavior when it's
Correct.
background, and also teenagers lots of suicidal tendencies.
Suicidal tendencies.
So I
Right.
think that should not be missed.
Okay.
Now,
Okay.
Nitish bhai, please continue. The choice of AED in generalized tonic-clonic epilepsy.
Okay, sir. So as Uday sir was saying, sodium valproate is something, it's as a blanket. Of course, in the newborns or infants, we would like to avoid that if possible. But of course, if it's SCN1 or something, we definitely will use it. Other things can be used are levetiracetam, especially younger children or likely metabolic disorder, or when you think it's conjunctivity and something is going on, or teenage girls will be using levetiracetam. Other things can be used for generalized will be say topiramate, even clobazam. So these are good standard drugs. And of
Okay.
course,
Now,
absence epilepsy. Sorry.
yes. Now, Rajesh bhai, in focal seizures without impairment of awareness, which is the choice of AED?
Actually, I think we are trying to be too specific over here.
Mm-hmm.
You must understand most studies which have been done in new onset epilepsy have shown that regardless of the type of drug which you use, the efficacy is more or less the same in all patients. Of course, in generalized seizures, as a general rule, you avoid the sodium channel blockers and you use broad spectrum drugs. But otherwise, broad spectrum drugs, whether you use sodium valproate or carbamazepine or oxcarbazepine or levetiracetam, the efficacy is more or less the same. There are certain groups which have, for example, valproate is a little more efficacious then levetiracetam as in juvenile myoclonic epilepsy, or for example, those things are there, the specific syndromes. But as a rule, it does not really matter that much.
Okay.
But if you have to use, I use oxcarbazepine and levetiracetam as my main go-to drugs in patients with focal impaired awareness or aware seizures.
Or even complex partial. Okay. What about myoclonic epilepsy, Rajesh bhai?
Myoclonic epilepsy, valproate is a very good drug. Benzodiazepines are good drugs, but again, they have a tendency to sort of,
Okay, Dr. Vinay, the
goes
infantile spasms, either benign or complex like Gestalt syndrome or
Yeah,
even.
so I think we have to, so that infantile spasm is, we have to discuss here a little more, I think.
Yes,
Because the
yes, please.
pediatricians should, the first thing is, I request all the pediatricians to think when a child comes at 3 to 6 months of age with some history of a perinatal insult or without perinatal, especially if you have a perinatal hypoglycemia, hypoxia history, and with little developmental delay, a child comes with recurrent recurrency, jerks, or even cry
Correct.
like an infantile colic,
Abnormal cries, yes.
abnormal cry, or a lack of a little regression, which is in a normal
Correct.
child. So that age, you have to go for an EEG when you
Correct.
are having a doubt. So with that diagnosis, and then the approach in infantile spasm is a little different from our stage, our other types of epilepsy, because this
Right.
is one of the epilepsy where we will have a kind of major impact on the development. So we
Correct.
go all out there. We have to
Mhm.
start injection ACTH or vigabatrin.
Correct.
Don't wait for valproate or this
Mhm,
go
mhm.
slow, start low, go slow thing. We have to start with a high dose steroids or ACTH or vigabatrin and treat it aggressively. Otherwise, the child will have most of the studies have shown that the lead time is very, very important. So try to think of spasms in any child at 6 months of age with an abnormal cry, and
Right.
investigate other causes. Along with that, you get an EEG, rule out dysarrhythmia,
Yeah.
and
What about
take it from there.
clonazepam, role of clonazepam?
No, clonazepam is not, see, in
No,
spasms,
in addition, as a
see, the point that is the kind of in spasms now, don't think of any other drugs. Valproate is given in the textbooks,
valproate.
clonazepam is given in the textbook, topiramate is given in the textbooks, but that's all in the last stages. Don't start like that and
Correct.
wait. So this is a medical emergency, seizure emergency, I will say. Treat it like status. So treat it like with a full dose of steroids from the first instance itself. So that is
I would just
the message.
Yes, Rajesh, please add.
I would just add something. Please ask in patients who are delayed, especially from perinatal brain injury, whether the baby is getting jerks, because sometimes
Correct.
these are missed by the parents and
Miss,
a lot of few
yes.
months go by. So you must ask actively and say, yeah, ऐसा होता है, झटका मारता है कि नहीं, या चमकता है कि नहीं, etc. So that you can pick it up early and or and treat accordingly. And of
Sure.
course, the
Nitish, now the
MOI
commonest, yeah, sorry. Yeah, go ahead, go ahead. Rajesh, you were saying something?
That's it. That's,
Okay.
that's it. No, so it's a
So
medical
Nitish,
emergency.
yeah, the commonest question parents want to know, when will we be able to stop the drug once you started? So when do you think of discontinuing? How do you withdraw? And what are the chances of recurrence in a child vis-a-vis an adolescent?
Sure. So I think a good thing is seizure medications are never forever, ever. I think you should always think for either options, stopping or surgery or any whatever other options possible.
Correct.
So we can say about say lesion positive. So if you have brain injury, these are different people, and if you have channelopathies or generic epilepsies, they are different people. So
Mhm.
if you have the straightforward self-limiting epilepsies, like
Yes.
selected things. So
I
I
think
think
the syndromes and those difficult ones or the Gestalt syndrome, spasm, they are going to go to the neurologist. They will take
yeah,
the care. The self-limiting epilepsy, generalized, some seizures, frequently infrequent, well controlled. Then the parents want to know when can we stop.
absolutely. So say
And that's the
self-limiting
pediatrician's
epilepsies.
forte. I mean, it's not going to go to
Yes,
the neurologist
absolutely, it
anytime.
was.
Yes.
So say select and all those kind of things. Either
Yes.
you are not treating, or if you're treating, if seizure frequency is not that frequent, so you can even stop after 12 to 18 months of seizure freedom.
Uh-huh.
These are self-limiting
And when
epilepsies.
you stop gradually or how
Okay,
many
yes.
days or
So never stop abruptly. So
abruptly.
always slowly,
Mhm.
even more slowly than what you started. So
Uh-huh.
at least over 6 to 8 weeks or 2 to 3 months.
Perfect.
So definitely very gradually, very slowly you cut back the doses. Uh,
Correct.
Other thing, if you have generalized epilepsies or genetic epilepsies, and if you're 2 years seizure free, say like childhood absence epilepsy,
Correct.
which is very common thing. In that case, if you're 2 years seizure free, again you can gradually cut back. But in
Mhm.
this child, I will definitely like to do the EEG, because you may have no obvious clinical seizures, but if your EEG is still abnormal, you have more chances of recurrence. So
Okay.
genetic epilepsies, especially say childhood absence epilepsies, who like to do that.
And
Um,
what are the chances of recurrence that the parents are interested in? After I stop, when will it recur? In what percentage does it recur?
Sure. So I think again it depends on kind of say self-limiting or genetic epilepsies or
No,
structural epilepsies.
self-limiting. We are talking
So
about
self-limiting.
self-limiting.
So as a self-limiting, chances of recurrence is very less. I would say around 10% or so, especially
Mm.
when child is very unwell or sleep deprivation. All those things can come back. If
Okay.
it's genetic epilepsies, chances of recurrence will be something around 20 to 30%. Uh,
And does it depend on the age? Like suppose adolescent will have more chance than a young
So
child,
I
or
think
it's not?
it's a syndrome classification. So like childhood absence epilepsy, chances of recurrence are less. JAE, juvenile absence epilepsy, will have more chance, and JME, of course, much more chance of recurrence. But of course,
Mhm.
it has to be discussed with a young person that when it's suitable to wean off. So it may be
Correct.
2 years, 2.5 years, or 3 years. But if they have 2 months, 3 months vacation after 12th or before going to uni, I think that's a very good area where child is more safe at home. They have 2, 3 months of vacation, and one can discuss safety aspects and gradually try to wean off and give a trial of weaning off in GME. If
Okay,
it's
what about doing an EEG in every patient or only in select patient? Repeat EEG before stopping.
so self-limiting epilepsy is not doing, but as I
Okay.
said, genetic epilepsy, especially childhood absence
Okay.
epilepsy, I will definitely do it before.
And
If it's
imaging,
abnormal,
repeat imaging like MRI, there were changes before. Now,
so again, those are separate group of people. So structural lesion positive, DNET, all those MTS. If that's seizure free for 3 years, I will definitely wean off and may not require neuroimaging.
okay, we have very little time left, and we two more modalities of treatment besides drugs we want to discuss in brief. So first, Dr. Vinayan, are you doing a lot of ketogenic diet? And if yes, what would be the indications?
The ketogenic diet, we are doing it. So we are doing a ketogenic diet and other types of diets also.
Uh-huh.
So the main thing here is ketogenic diet is a kind of an added thing in a drug-resistant epilepsy where we are not going in for surgery. That is the way we go it, because
Correct.
the primary thing is when you have a pharmacoresistant epilepsy, around
Correct.
20% of all epilepsies may be pharmacoresistant. So if
Mm-hmm.
you have a pharmacoresistant epilepsy, the first thing is whether it is a surgically remediable
Correct.
surgically remediable. If it is not surgically remediable, then the other options are we can add on a pharmacological diet on top of this. And there are some metabolic disorders like a glutathione transporter syndrome. If you think of those kind of syndromes where the ketogenic diet is the primary treatment option.
Treatment. Okay.
So that is also when you have a diagnosis of that, we might go for that. But otherwise,
And
it is
what percentage of children who you put on ketogenic diet actually have some benefit?
that depends. See, it is. I will not say that it is a general thing, but
Uh-huh.
I'll say that in a majority of children, if you adjust the diet, there will be some difference.
Mm-hmm.
Okay, but whether that difference is a kind of seizure freedom, not very few people get seizure
Correct.
freedom after the diet in a pharmacoresistant epilepsy.
Correct.
But their seizure control of less than 50% seizure control, especially one syndrome we can think of as a very good for the ketogenic diet is a myoclonic atonic epilepsy.
Correct.
If you have an MAE syndrome, the syndrome will respond beautifully, or it is kind of some of the children may melt away. The seizures will melt away with diet.
And
But
how long will continue?
that depends on again
Suppose
the
there's a
time.
good response.
Yeah, that is the thing. So the tolerability is a problem. So it is a
Mm.
point is whether the child is tolerating, the family is
Mm-hmm.
able to continue it. So the first thing which when I get a seizure freedom in that kind of situation, I'll check for any kind of deficiencies or any of those things, any side effects is occurring. We understand that ketogenic diet is like a drug. They can have renal stones, they can have
Correct.
deficiencies, they can have other nutritional deficiencies. Then some people can become overweight. So many issues are there. So you have to monitor depending on, there are no side effects. Usually what I'll do is you continue for 6 months, try to taper it off. But in some
Okay.
cases we will continue for long also. But the longer you continue, there is chance of more side effects because of the nutritional deficiencies which can occur.
Okay, and I think the last modality that we are doing a lot at Hinduja, and I'm sure now there are several centers doing it across the country, is the surgical treatment for epilepsy. Dr. Brajesh, the indication of epilepsy surgery and
Well, I think,
youngest age when you can actually subject someone to something like that.
yeah. So one is that drug-resistant epilepsy should be referred to a comprehensive epilepsy center.
Perfect.
Because primary thing is that you need to exclude pseudo resistance first and make sure it's not some other metabolic condition like something, or it's
Correct.
because of poor drugs or whatever it is. And then you have to decide whether there is a surgically remediable syndrome. Now, the surgical remediable syndrome is expanding, but there are some low-hanging fruit. If you see a lesion on the MRI, or if there's something which is easily tackleable, like a tumor or hippocampal sclerosis or whatever it is, these things are easily taken care of,
Correct.
especially if they're in safe areas, not eloquent areas, and you don't necessarily have deficit, will have a deficit after that. But this surgical remedial syndromes are now expanded. You may can go on to have MRI negative epilepsies. You may have multiple lesions also, and you have to decide which particular. So these things can be done only in a specialized center. And over here, for example, you do a lot of, for example, the epilepsy MRI which we were talking about. Nowadays most epilepsy centers will do a volumetric MRI. So you're taking the entire brain in different sequences is taken at once. So you can actually go very slowly and exactly look for some subtle changes like focal cortical dysplasia, or there's some other malformations of cortical development, etc., which underlie surgery, which underlie the epilepsy. So basically, you have to have where everything is done. Then there's post-processing, there are PET scans, there's video EEG, all these things which are available. And of course, you have to have a very good team of an epileptologist, a neurosurgeon, etc. And the basic premise is that if it is something which can be resected safely, the epileptogenic zone, as it was previously called, but over here, the critical part of the epileptogenic
Can't hear you
network.
well.
No, so if you remove that part of the epileptogenic zone and can cure the focal epilepsy, that's called resective surgery.
Correct.
And that should be what people are looking for in the epilepsy center. Once it is not there, or there are multiple epileptogenic areas where you can't determine, then you go for the alternative treatments, like surgical treatments, like the neuromodulations, like VNS, etc., which can be used. And of course, before that, I would try the diet.
Correct. Youngest child?
Well, we have done the earliest at 2 months of age.
2 months.
Patients of hemimegalencephaly. So we had actually operated at the age of 2 months. Of course, there's a risk of bleeding and all this I explained, but there was no option, but we had to, because the patient was fitting 100 times a day.
I remember when I was a student, Dr. K. Shaishu said, when you don't understand, just start valproate. It would probably work in most of the epilepsies. Does that rule stand still?
I wish it
That
did.
is, yeah, that
Yes.
stands because the valproate was the broad spectrum drug then.
Yes.
Many of
And one of the safe drugs.
Now, many of the newer drugs are broad spectrum. Levetiracetam is a broad spectrum drug.
Correct.
Brivaracetam is a broad spectrum drug. So that is the best thing which has happened in the AED therapy. So
Correct.
that stands. You start with a broad spectrum drug. That's what the Udanis are also telling. So
Correct.
it doesn't mean that you have to. It is better if you start with levetiracetam. You will be able to control almost all the seizures except absences is the one seizure,
yes,
which
correct.
you have to be little careful because absences may not be controlled by the
Deteriorate, correct, perfect. All right, I think we had an extensive discussion on epilepsy and the nuances and the drugs, and it's a very vast subject. I'm sure there is a 2-day workshop with multiple lectures and hands-on only on epilepsy can't be discussed in 1.5 hours, but we try to do that to the best ability of we as a moderator, and of course the panelists are excellent neurologists in their own standing. So thank you everyone. Thank you very much for your absolutely wonderful display of common scenarios in epilepsy and how to tackle the different parts of the epilepsy. Dr. Ramesh, you can conclude.
Yes. As Nitin Bhai, you said it very correctly that these three experts, they have made such a complex subject, I mean, in a presentable manner, so that I'm very sure that our viewers must have enlightened. And on a lighter note, as far as sodium valproate is concerned, because of this common knowledge, even medical officers, they are writing sodium valproate in government hospital for any type of seizures.
Oh, wow.
So thank you, Rajesh Bhai, Vinay sir, Dr. Nitish Bhai, and all our dignitaries present here. And of course, I mean, not last but least, Dr. Nitin Bhai, always backbone of our academic programs. Thank you so much, Nitin Bhai, for preparing in such a way that it was like a poetry and in a flow manner. because the subject is actually very complex, and especially people who are practicing in periphery, they will definitely find it very helpful. Thank you so
Correct.
much.
Our next session will be on the not 4th but the 5th Friday, that is 30th May. With the 4th Friday, I'm stuck up with some personal work. So 30th May is when we'll come back with something even interesting as today's topic. Till then, have good night, and everyone, thank you very much for your patient hearing.
Thank you, sir.
Thank,
Good
Thank you very much, sir. Thank you.
thank you so much. Thank you so much, everyone.